Thanks a lot for invitation. It's really an honor for me to be here, truly. And because my exposure to the lymphatic world was kind of sketchy. During the last 3-4 years, I started to attend meetings and I learned a lot. I expand my talk a bit beyond the endovascular repair of thoracic duct to show you what else we're actually doing right now. So this is how my view of a lymphatic system, and my approach is completely different than Dr. Roxon, because we come to with this mechanistical plumbing approach. So we will see it as a reverse tree, and I clearly define 3 different lymphatic systems. It will be peripheral lymphatic system, liver, intestine. And the reason why we describe it, we feel it's 3 completely different systems is because the lymph is different. For example, we know pretty well, although there was some discussion about that today, is that liver lymph that completely under investigated contains almost 80–90% of proteins, and they're low concentration of lymphocytes. Intestinal lymph contains a significant amount of lipids and 60% of proteins, and in the peripheral lymph there's almost no proteins, 5–6% of the blood level, albumin. The flow is completely different. Enormous flow in the liver lymphatics and in the intestine. They contribute approximately 80% of the flow in thoracic duct, and pretty much non-existing flow in a resting condition in the lower extremities, and obviously increased flow in the soft tissue muscular lymphatics during exercise. So, well, if you look at the literature, it was 60s, 70s, starting with Starling, 1896, everybody been obsessed with the lymphatic system. You can see any possible experiment, human, animal, testing the concentration of albumins, flow in the lymphatic system. And then 40 years, almost complete silence. There's obviously a lot of studies done on the rodent level, but nothing on the humans. And the reason for that is it's extraordinarily difficult to image lymphatic system. And there were no interventional techniques. So this is what we used to have, pedal lymphangiogram and lymphoscintigraphy, and maybe another 2–3 obscure techniques. I used to do it for 10 years, and I hate it every day because it's very, very tedious, and I know that David Hovsepian likes that. He's probably the only one at Mayo Clinic also do that, and I occasionally do that, but nobody liked it. And the reason why it's important is because it was a major obstacle to everybody I get into this lymphatic intervention. So what we came up during the last 3 years is 2 techniques. First, intranodal lymphangiogram. We described it approximately the same time as a group in Boston. There's non-contrast enhanced MR lymphangiogram that Dr. Roxon just talked. Recently, we didn't discover that. We didn't describe that. And there's a new technique that become a main techniques for us to diagnose lymphatic disorders, contrast enhanced MR lymphangiogram. Intranodal lymphangiogram is very, very simple. You just take the needle, take the ultrasound, see lymph nodes, stick there, and immediately you got images like that. I don't know why David doesn't like it, but it's very, very easy. He could. This is the reason why my practice of traumatic thorax almost non-existing right now, because everybody in my town do that. So I used to have 50–60 cases a year. Right now I maybe have 10. But from the other hand, I get all failed thoracic duct ligation or failed embolization. That's much more fun. So this non-contrast MR lymphangiogram is very simple. You use heavy T2 sequence, water sequence, similar to MRCP or MR urogram, and you can see this dilated lymphatic ducts. Here it's a study from Japanese literature. The reason why we can see it that nicely because we actually compress the thoracic duct with some kind of pads. Usually you don't see that well. However, when do we use that? For example, in a patient with severe right-sided heart failure, this is all lymphatics. This is extraordinarily dilated thoracic duct, bilateral pleural effusion, and what we often see, this is enormous masses on the neck and chest and the retroperitoneum because of overflow lymphatic phenomenon. So it's too much flow going in its lymphatics. That's the reason you see this always collaterals. We summarized it and published one day. So fortunately for us, we have this amazing device that's called XMR. It's only a few places in the country have it. I think UCSF, Hopkins, and Northwestern, and us. Children's Hospital, not Penn. So this is the table from the cardiac cath lab connected from, say, rails to MRI. So why it's important? Because we actually can do MR lymphangiogram. We can put the needles inside the groins, outside the MRI using ultrasound, confirm position with fluoroscopy, and slide the patient inside the MRI. You cannot transfer a patient from table to table because the needle gets dislodged. And that's what images you got. This is a normal thoracic duct. You can actually do almost real time. It's over 10 minutes injection. This is normal, and this is clearly, oops, can I go back? Yeah, and this is clearly abnormal. And this is a patient with idiopathic chylothorax. You can see that this is correlated imaging. We inject contrast in thoracic duct, and you can see that there is enormous flow, much more better appreciated actually on MRI than on the lymphangiogram of the lymph inside the lung. We actually can see what's the cause of congenital lymphatic dysplasia, first time. It's absence of a thoracic duct and flow of the lymph inside the tissue. So for us, it's a big thing because we actually we have a tool that nobody ever in the world had where we can actually investigate what's the causes of diseases. And during the last 2-3 years, we actually discovered the causes of the diseases and developed a treatment. So what about therapy? This is my hero, Dr. Konstantin Kopp. He is a father of interventional radiology. He is inventor of many, many, many devices. He is the one that conceptualized the idea that you actually can do some lymphatic interventions. You can actually go inside thoracic duct and do something. So he was my mentor. And we started with thoracic duct embolization. Right now, that's where we stand. We have not thoracic duct embolization, we call it lymphatic embolization because we use different techniques. We treat chylothorax, plastic bronchitis, pulmonary lymphangiomatosis. It's a primarily GLA, Gorham disease patient, definitely chylous ascites. We started to look very, very closely, very successful in liver lymphatic embolization, lymphangiographic embolization, treating ascites, CHF-related ascites, and maybe also liver cirrhosis ascites, protein-losing enteropathy, liver lymphoria, and this is a new thing for us, thoracic externalization and thoracic duct stenting. So the concept of thoracic duct embolization was very simple. You do a lymphangiogram, you see the leak, you take small needle, stick inside, inject something to close it, and that way you can increase your success and decrease complication. So we start with, right now, intranodal lymphangiogram. Then we will take a small needle. This is testernacali. We go through the abdomen for every structure in the abdomen. And when I say every structure, I mean colon, stomach, aorta, IVC. Put the needle and put the wire inside. It's absolutely safe. I did almost 450 right now cases. We practically don't have a complication. Only in the small children, newborns or premature, they can get sick from the procedure for 1 or 2 days. So you saw here the wire goes inside thoracic duct. This is catheter inside the thoracic duct. You can see that this is a pericardial effusion, traumatic leakage in the pericardium. We embolize that, coils and glue, always for the embolization of the thoracic duct. Here's the coil, straightforward, very, very non-stressful. There is nothing to loose here, you just deploy the coil, create a matrix for the glue to come, and then you inject glue. Glue is radio opaque, so you can see it's actually on the screen. So this is our success rate we published in 2010. 88%, pretty good. It's probably the best in the literature. Right now, we climb to 96% because our experience is much better. We just submitted as an abstract, is accepted, and we're going to publish it pretty soon. A lot of these cases, you can see, coming after unsuccessful thoracic duct ligation. We have a separate paper on that. Non-traumatic cylothorax, much more complicated. This is an example of a patient with extended history, so not with extended histories, with occlusion on narrowing of the thoracic duct and reflux of the lymph inside the lungs. So this is our study from 2012, summary of first 34 cases, and idiopathic, it's primarily idiopathic. Very interesting that the female to male, there was primarily female, 2-to-1 ratio. I don't know why. And when we look at the data, it was not that good actually. It's only 67% success rate, not as good as 53 and intent to treat, not as good as thoracic duct trauma. So we look back and look at our images and realize that we actually have two groups of the patient. One with occluded thoracic duct or leak, where we can actually see the success rate actually almost like traumatic. But normal thoracic duct, 16. And why would we embolize normal thoracic duct? Because when we started to do the procedure, we did exactly the same as surgeons do. Chylothorax means thoracic duct ligation. We said chylothorax means thoracic duct embolization. We didn't know any better. And obviously it doesn't make any sense. So in occlusion thoracic duct, you can see here what happened. There's occlusion of, here's probably acquired occlusion of the thoracic duct. This is a dialysis patient that there are multiple collaterals develop, and then one of these collaterals, and this is compensatory mechanism, that's what's supposed to happen, but then one of these collaterals actually touches the pleural surface of the pericardium or bronchi or pleural, and you can see here, this is a patient many years ago we did. This is small dots. It's actually pericardial occlusion of the thoracic duct here, flow of lymph alongside the pericardium, and all these dots, it's actually a contrast in the pericardial lymphatic. So one of these lymphatic is leaking. This is another example of congenital occlusion, lymphoma, the same thing, occlusion of the lymphatic vessels. This is absolutely healthy 22-year-old, suddenly developed massive Chylous effusion. We do right now MRI, and you can see clear leak from the upper part of the thoracic duct into the pericardium. Here it's the same patient. We see it selectively in this branch, and you can see the contrast go all the way down into the pericardium. Embolization cure her. So let's say you have what happened with normal thoracic duct? People have a chylothorax, normal thoracic duct. Two diseases. The most important one, chylous, and then lymphatic masses. Like I would probably not supposed to say lymphangiomas, lymphatic masses. Why chylous? Because there are holes in diaphragm and negative pressure in the chest. So, and if the leak happens in the abdomen, such as it's the same thing, a hepatic hydrothorax, it's the same probably thing as a right-sided heart failure, pleural effusion, where the holes in diaphragm and a negative pressure in the chest, where the contrast go inside the chest. This is a intraoperative images. This is diaphragm. The patient with chylous and pleural effusion, you can see here. Holes at diaphragm and contrast coming from below the diaphragm into the chest cavity. The other cause is lymphatic malformation, retrocrural. It looks like it sits in the abdomen. It's actually not. It's retroperitoneal. So always retroperitoneal masses almost never give you chylous. They always give you chylothorax. We just summarize our data. It's not here. We have another 37 patients with new patients with idiopathic chylothorax that were treated with algorithm I will show in a sec. So what you do with these masses, you inject glue or inject Or sometimes you just puncture with a needle, they bleed, and they close the duct. So this is our diagnostic workup. First and most important, exclude chylous ascites. You don't know how many patients come into me and with chylothorax that are actually chylous ascites. Last week I have 2. Next we'll do a MR lymphangiogram. Is again to look for abnormal lymphatic perfusion and look for the lymphatic malformation. And then we'll do congenital conventional lymphangiogram or internal lymphangiogram. So this is algorithm. Chylous ascites, you can try different treatments. Eventually, my experience, most of them come in to the dental shunt. We have some successes with the idiopathic chylous ascites. With maybe 10 patients, we've been successfully find the leak and glue it. A lot of time, you cannot do that. If it's not chylous ascites, we do MRI, and as on the previous slide I showed you, we're looking for the lymphatic malformation and abnormal lymphatic perfusion, and then we'll do embolization if it's occlusion, or leak, or sclerotherapy, or right now, glue injection. Switching gears, so when we have this amazing new modality that nobody ever used, you can discover stuff. So one of the things we discovered, what's right now we call pulmonary lymphatic perfusion syndrome, or what's used to be known as a lymphatic reflux. And the idea is here the following. Most of the lymph is generated below the diaphragm, intestine, liver. It has to travel uninterrupted in the thoracic duct into subclavian vein. In these cases, in cases of pulmonary lymphatic perfusion, it goes inside the lungs. So this is a normal you already saw, and this is something clearly abnormal about that one, but it doesn't show up. I'm not sure why it's not coming. Okay, we have more. We have other examples. So here's another example, right? This is clearly something abnormal here. This is lymph going inside the lung parenchyma. This is a patient with plastic bronchitis. This is a 70-year-old, absolutely healthy patient with plastic bronchitis. The same thing. Lymph, instead of going inside the subclavian vein, actually going toward the heart, around the heart, and perfuses the lungs. So these are the 3 diseases right now. We clearly identify having this pulmonary lymphatic perfusion syndrome. Plastic bronchitis, most of the cases, 90%. We have right now 40 patients over the last 1.5 years we treated. Pulmonary lymphangiomatosis. And here, I kind of cheat here because when we say pulmonary lymphangiomatosis, what do you mean, right? And it's another sack or sink of different diseases that kind of we decided to call. This is primarily GLA, Gorham disease, and Kaposi form with pulmonary component. When they present, it's kind of funny. Then they present young, they get this GLA and Gorham. Then they present older to the pulmonologist. Pulmonologists will call them pulmonary lymphangiomatosis. And non-traumatic chylothorax, I just show you. So this is plastic bronchitis. This is kids or adults. We have both cardiac-related and idiopathic, where they started to call this cast of the lungs. So for years, people have been saying there's something lymphatic about that, but nobody actually, because when you biopsy their bronchi, they can see lymphatic tissue. Some people advocate thoracic duct ligation was successful, a few case report, but actually nobody ever looked into that clearly. So we have a new tool. We can do that. So here we inject. This is a kid with plastic bronchitis, Fontan, and as you can see here, lymph, instead of, this is IVC, disregard that. This is lymph. Instead of going straight and beautiful into the subclavian vein, it takes actually to the right, up, and left, and perfuse the right hilum. You actually even can see the bifurcation of upper and lower bronchi. So when we get inside the system, selectively, we're sitting right now inside the branch. You can see that contrast actually flows toward the hilum, and that explains everything. So we just embolize that. Oops. Oh, and then we inject methylene blue while we perform bronchoscopy, because we kind of started to do it recently, but it's very, very useful for us to understand, and you can see immediately what's going on. This is clearly lymphatic perfusion, and leakage, in this case, is pure leakage. Most of the time, you just see kind of a network of lymphatic vessels within seconds after you inject. Embolization of this branch with lapidol and it's oily embolic agent, and then glue cured these children. We did almost 37 right now. This is our data we just submitted in circulation. We have 18 patients in this data set, 94% significant improvement. It's either 56% complete cure or significant reduction of the bronchial casting. Some of them coming back right now because the first partially successful cases, they are, we just didn't know how to do right. So we just kind of learning how far we can go, and we can go actually pretty far, completely occlusive lymphatic system. We try to maintain still patency. Lymphangiomatosis or pulmonary lymphangiomatosis, lymphatic anomalies, all these subtypes of diseases that have pulmonary involvement. We have 4 patients. This is patient number 1, presented as interstitial lung disease. Of course, since she's 7-year-old, we biopsy this lung disease, and immediately she developed chylothorax. This is clear interstitial lung disease, by all means. This is our injection. We're sitting inside the thoracic duct. I did it in a different country, so I don't have MRI. But this is it's our first case. So you can see clearly nothing goes to the subclavian vein. Instead, all lymph goes, you couldn't see it here, but also on the right, left and right, into the subcutaneous interstitial tissue. And this is actually explain why she has this interstitial pattern. And we embolize it. It looks messy, but this is coil deployment. We inject different, because it's such an enormous one, I did use different techniques. In this country, we didn't have a glue, something other stuff. So this is her chest x-ray immediately after procedure. This is 6 months later. I just saw her 2 weeks ago, and she's doing extraordinarily well, gained weight, and pretty much they take care of sirolimus right now because there's no reason to have sirolimus. The same neonatal chylothorax, where you have kids that born with chylothorax, and I don't have a timer, so I'm not sure. I still have 20 minutes, right? It's till 5:15, right? Yeah, okay, I have time. So exactly the same thing, congenital, absence of the upper part of the thoracic duct with reflux of the lymph inside the pulmonary lymphatics. And just lipidol injection actually cures this kid. But you have to be very, very careful, not inject too much, because you completely, with neonates, you can completely block the lymphatic system. And I would, if somebody decides to do that, talk to us first so we can guide them how to do that. So this is pulmonary lymphatic perfusion. This is diseases we know out there. We clearly realize that it's congenital lymphatic variant. Why? Because lymphangiographically, they look neonates, and 70-year-old absolutely healthy developed plastic bronchitis looks exactly the same. So this is congenital lymphatic variant that probably present 5 to 10% of population. Because why? Because Fontan kids, 5 to 10% Fontan kids develop plastic bronchitis. And this congenital lymphatic variant could never present, or can present under stressful conditions such as Fontan, where there's an overflow of lymphatic fluid, or all our idiopathic adults, or almost all of them, have severe flu before they develop this plastic bronchitis. So maybe it's damage of the mucosa. And correction of this lymphatic variant is actually very successful to treat this condition. So we think that some form of CHF definitely have it. We think that some chronic cough patient has that. Why? Because all patients, we have 8 adults right now presented to us during the year with plastic bronchitis. All of them have several years of chronic cough, unexplained chronic cough, before they cough they cast. And we think about bronchopulmonary dysplasia and probably some interstitial lung disease. So we think it's the tip of the iceberg, and we discovered more and more diseases as we go. Switching completely gears to new, and it's outside a little bit my title of my talk, but liver lymphatic system, and it's very, very exciting, and we're excited about this new modality. So starting obviously the first who described that, and As I said, normal lymphatic liver lymph generates 30–40% of the flow in thoracic duct, estimated 500–800 cc a day. And interesting, 40% of total body proteins return to blood circulation from thoracic duct. It's all these coming from data from 50s and 60s studies. I didn't put the references, probably I have to. And if you ask any hepatologist, the most sophisticated one, what's the changes of the liver lymphatic system in liver cirrhosis? And the answer will be, we don't know actually that liver has a lymphatic system, right? And it does. And there are changes. So, and when you look back in the 60s, 70s, the concept of ascites in liver cirrhosis was that the liver generates too much lymph because it's congested, and it's whipping out of their surface. It's obviously replaced right now with aldosterone theory, but I will maybe convince you that there is something about that in a few slides. Liver lymphangiogram, it's curiosity. If you ask any interventional radiology, have you ever done liver lymphangiogram? You say, yeah, of course we did. When you do biliary drainage, accidentally, or tips, you stuck into lymphatic duct and you see them there. So all these studies, this is pretty much that. Oh, we actually saw that. Did we do anything about that? Pretty much nothing besides one case report and the liver, and obviously, Japanese or Asian physician, they do extensive nodal dissection. So they're looking for the techniques to image lymphatic system. So there's some liver nodes, metastasis papers out there. So this is our experience. We know how to treat liver lymphorrhea, ascites and CHF, and protein-losing enteropathy, and it's just the beginning. We only have a handful of patients, but it's very, very promising. This is a patient we published a few years ago, presented after Whipple, and 6 liters a day ascites. We did, and kind of they thought maybe it's Chylous, so they referred it to us. He came to us, and we did regular lymphangiogram, found nothing. And during the time, I just started to think about liver lymphangiogram and importance because I was reading a lot of old literature. So let's stick a needle and see what's going on. And obviously, this patient has liver hepatitis or liver cirrhosis. So immediately after we did liver lymphangiogram, we started to see the leak. And you can see it here. It's clearly the leak that originates in the liver lymphatics. The moment we glue them, we use onyx during the time. He had only one paracentesis and cured from ascites. This is another, we have 3 patients like that, ascites and right-sided CHF. So why did they come even to us, right? Because there is overlap between chylous and non-chylous. So the definition of the chylous lymph is still out there. I convinced, dealing with it for 15 years, we still don't know what's actually the chylous fluid. So they came to me as of chylous, but I kind of understand that it's actually not. And we decided to do liver lymphangiogram. And what you can see here, disregard this bubble just leaking into the peritoneum, but you can see enormous fast flow of this lymph into not thoracic duct, how it's supposed to be here, but into the mesenterium. And if you wait a little bit longer, you can see, yes, absolutely. Can you see thoracic duct? Sure, this is the sternocali. But before it's reached the sternocali, it actually flushes through the mesenterium. And gluing, and what you see here is a glue cast, completely cured this patient. So we have 3 like this. I think it's almost the first time I'm presenting this data. It's only a few months. But we right now design a control study where we're going to bring all these patients. And we still have 3 patients clinically that suffering from ascites coming to us. But we'll do it not as a Wild West as we usually do, but something more controlled. Protein-losing enteropathy, it's a loss of albumins into the intestine. And every time you do scope this patient, you actually see lymphangiectasia. So everybody knew that it's something about lymph because you can see this lymphangiectasia. But is it really connected some way or where it's coming? So for truly make it it will be short here, but I will tell you 1.5 years we're struggling with that. We went in thoracic duct, we inject different locations, we felt it's reflux we couldn't find until we came to this concept. We said, okay, we know that liver generates albumin 12.5 grams a day. We know the liver lymph have a high concentration of proteins based on the old literature, and as I heard there's some discussion about that today, but that's what I know from the literature. We know that lymphatic flow increases significantly, liver lymphatic flow increases significantly in CHF and liver cirrhosis. So maybe it's coming somehow from the lymph, where the liver lymph, so liver lymph leaks inside their intestine. So let's do liver lymphangiography. We know how to do that, and maybe we can embolize it like we did with liver lymphuria. So this is our first patient. The moment we put needle outside, immediately we can see the leakage of the contrast in the duodenum. And if we inject blue dye while we're doing an endoscopy, absolutely. It's always the same location. It's 1 or 2 centimeters above the ampoule of water. We have 5 cases. Does it work, embolization? It does work, however temporarily. So this is the first patient we injected with Lapidol. We thought we were going to embolize with Lapidol. She improved up to 4 and then slided back. Patient number 2 decided not to wait and got heart and liver transplant 2 weeks after our procedure. Usually takes 1 month before the albumin climbs. And patient number 3 improved significantly for 6 months. It's not updated slide. It's actually slide down right now after 6 months. So the mechanism is clear there. We don't know yet how to treat it right. We discovered recently the second cause of protein losing enteroscopy. We have these 2 patients post thoracic duct ligation. When we inject MRI, we can clearly see this occlusion of the thoracic duct, but we also can see here. This is thoracic duct stump, but also reflux of the contrast inside the retrograde flow in the intestinal lymphatics. And you wait a bit longer, you can see the filling of the intestine with contrast. What can we do about that? We embolize it. This is a stump of a thoracic duct. That's where they ligated it. So we get from here, climb all the way into the intestinal lymphatics. It's very, very hard to understand, but this is tip of our catheter, and you can see this is retrograde flow, go all over the intestinal lymphatics. And this is a glucose, and this kid from Arizona, she's 2-year-old, 4-year-old looks like 2-year-old, been in the hospital for a year, completely cured. And we have 2 cases like that. The other kid is from Chile. It came to us. We just submitted as to publication, and we got just first review. Liver lymphangiography and embolization will serve a big role, future role. And we're trying to push it as strong as we can. The last thing, thoracic duct externalization and drainage, and stenting, sorry. It was kind of explored many, many years ago for all these different diseases. T-cell depletion therapy before kidney rejection, CHF, diagnostic infectious disease. The problem is it's always been done by surgeons that they cut the skin and try to find something. They actually couldn't see that much. The surgery, there was quite a complication rate after these procedures. Can we do it better? Yes, we can. This is this paper from Whittier, of course, where they did 12 patients, acute drainage of the thoracic duct. So if we can use MRI to understand anatomy, we can use minimally invasive technique, we can improve procedure time and achieve better result. So this is an example of a kid with congenital lymphodysplasia, and you can see the same thing. This is contrast go somewhere in the soft tissue, and that's the reason why this kid is swollen. And this is how I see that. Instead of going into subclavian vein, it actually goes back into soft tissue. Can we drain that? Absolutely. So here you can see we inject contrast below. This is the same patient as you saw MRI. Contrast climb all the way up, and here the thoracic duct splits in thousands of different branches. But there's one main one. So what we do our magic. So unfortunately, this doesn't play. We do our magic, put a sheath inside the thoracic duct in the cisterna cali, and then we drain it. And magic happened. This is a kid, and this is 12 hours later. It's actually completely decompressed. And so we know what's the cause of his hydrops, occlusion of the thoracic duct. So unfortunately, this kid is our first one. We've been training him for 1.5 months because we kind of didn't know. We know how to fly, we don't know how to land, right? We know he's leaking 1 liter a day, but what are we going to do about that? So we kind of designed, kind of set up, but eventually it's turned out that he almost doesn't have a brain, so they decided to discontinue care. But this is our solution, new solution. This is a kid that was born swollen as well, and you can see when you do MRI, nothing goes in thoracic duct, but when you sit selectively inside the thoracic duct, you can realize that, yeah, absolutely, there is no communication between thoracic duct and subclavian vein, or maybe tiny one here, you maybe see it a bit later, but most of the stuff is actually go to subcutaneous tissue. Fortunately for us, we have amazing endovascular microsurgeons, what we're convinced to do lymphovenous anastomosis. And here, the lymphovenous anastomosis, is it a good one? Absolutely not. Horrible one. But it's our first experience. But it's actually patent. This is 2 weeks later. You can see the thoracic duct is significantly smaller. Clinically, the kid is doing much better. And the anastomosis is patent, even not good one, clearly not technically successful. And this patient is still in hospital, so I couldn't tell you what the outcome. But clinically, he is much better now. So we potentially has this solution of subclavian vein or thoracic duct to some kind of vein anastomosis. And this is unfortunately the only solution for these children. Can you stent thoracic duct? Yes, we do it extensively on the swine. It works pretty well, very, very easy. Can we do it in humans? And you can see this is post-stenting on a pig, normal thoracic duct. Absolutely. This is a child with plastic bronchitis. Remember, he came from Austria to us, I guess, and you know, he came with all his like family and friends and physician, and suddenly we actually don't see that much perfusion on MRI, and we kind of get scared. So maybe we brought him for no reason. So, but when you occlude the thoracic duct with a balloon and inject, you actually can see that this perfusion getting better and better, bigger and bigger. So, so when you do our injection, that's good by the media. You can do our, it's here. So you can do our injection blue dye. Absolutely, this is the same kit. You can see all this perfusion by lymphozurin of the subcutaneous, and that's actually 20 minutes later. You see the cast is actually colored with contrast. So can we do stenting? Yeah, absolutely, and we did. And as you can see here, the stent comes. He was big enough. It's the biggest stent we have, 5 millimeter. He was big enough. And here we inject contrast post-stenting, and you can see we completely excluded this area, and he is cured. So where are we today? We treat chylothorax, pretty much 100 success with traumatic. We have almost 100 success rate in treatment of non-traumatic. The only case I'm struggling is a case of 75-year-old LE&RN patient. She's coming to me next week again. It's embolization number 5 because they actually leaking not from thoracic duct, but from multiple masses that retroperitoneal masses. We clearly understand etiology of plastic bronchitis, most of that. We have 2-3 cases where it didn't have lymphatic pathology. We clearly understand and can treat successfully neonatal chylothorax, isolated neonatal chylothorax, because when patient presented with diffuse swelling, ascites, and chylothorax, that's one of the most difficult conditions to treat. But if patient has or kid has only chylothorax, we can treat it. We clearly knows what's the cause of at least some types of protein-induced enteropathy. We still think developing a treatment will be successful. We just need a bit more time. We clearly understand we have 4 patients where we imaged pulmonary lymphangiomatosis that has this retrograde flow, and we treated 2 successfully. We have some success with very successful traumatic callus ascites. We have some success with non-traumatic callus ascites. This is our future. This is future for HIV, for maybe treatments to CHF. I know Stanford, some group in Israel working on that. We definitely started to actively talk about CAR immunocell therapy. This is another two promising areas. We subcontracted two imagers, researchers in the PAN, and we are working for us to try to develop this liver lymphatic imaging agent and intestinal. This is look very promising already. And CHF, obviously, think about that. And this is lymphedema. We stay away from lymphedema for many, many years. Right now, we started to face it. So this is just an example of a patient that Stan, you know pretty well. And this is enormous thoracic duct, enormously dilated lymphatic vessel, and very, very narrow communication with a vein. Can we stand and do something about that? I think so, maybe one day. This is our team, and it's growing. We have another 3 people hired right now. There's a Penn and Chop created the Center for Lymphatic Imaging and Intervention. It's still not officially, so that's the reason it's not there, but it will happen pretty soon, and we'll continue to work on all lymphatic imaging and intervention. Thank you very much.
Questions from the audience? And I mean, it's fascinating. I really enjoyed your talk. I have a question about when you do the contrast enhanced MR lymphangiogram, how long does it take? And for the kids, they're under anesthesia?
Yeah, absolutely.
And how long does it take?
Probably half an hour, 40 minutes. Adult we do without anesthesia, local, because we continue to do adults at CHOP, because we use kind of this fancy system, and as a pediatric hospital, they limit us up to 24-year-old to give sedation or anesthesia.
Can you just clarify what information you get from the contrast-enhanced MRI that you don't get from the heavily T2-weighted image?
We can understand much better the lymphatic flows. For example, we can see the this pulmonary lymphatic perfusion. So we actually can address, and it's, we're just working on the data. It will take us a year, probably. We have almost 150 MR lymphangiograms already to try to summarize and understand. And we actually in a very disadvantaged situation because we don't know what's normal, truly. And there's one study we designed for CHF patient where we clearly said we need to recruit 10 normal patients to understand how it's look. It's a completely new modality. And based on this MRI, you can see the area of perfusion. You can see the reflux into the liver. You can see the masses much better than you do with just a T2 lymphangiogram.
Do you have any experience in looking at the peripheral lymphatic anatomy with the T2 weighted imaging? So in the limbs?
It's T2 weighted. You're talking about lower extremity,
legs or arms. I'm just wondering, how useful that.
We just started to do lower extremity lymphangiogram like Asians do, and because of this first case with lymphovenous anastomosis, we started to collaborate with our, and they want that badly. And we kind of understand that maybe this is the best, I'm not sure 100% yet, but this is maybe the best way to image peripheral lymphatic system by injecting gadolinium between the toes. Yeah. With just only one case right now. And
I know that Corinne Becker, who's the originator of vascularized lymph node transfer for lymphedema, in her center in Paris, they're using exclusively T2 weighted imaging.
And now plastic surgeons learn there, so he wants that. And it's probably good technique.
Yeah.
Very nice talk, Max. I would just like to, it's not so much a question as a comment. So your description of the lymphatic vascular bed as this inverted tree, I think is a classical one. But in fact, what we have is hundreds of trees. Each of the trees corresponds to a particular tissue bed. And you talked about the biggest ones because they are the biggest ones and they drive the most lymph flow. But in fact, what we've got is lots and lots of these types of trees that all kind of link together into a couple of normally, on normal conditions, a couple of normal main trunks that go back to the venous circulation. And one of the problems that we have when we're starting to look at different beds and trying to analyze flows here and flows there and pressures here and pressures there is it's phenomenally complicated. So it's not So I don't know if you've driven around at all and seen any of the mangroves nearby. So it's a trees, it's a cluster of trees, but it looks like the mangroves that you see in the swamps around here, where these roots and beds and interactions from one trunk to another are so complex and complicated. It's really tough to figure out. And it's all those pressure gradients when you bring these different trunks from these different beds together that really drive where lymph flow goes under normal conditions and in abnormal conditions.
I absolutely agree. And that's a problem. Why? And that's why let's keep people away from the lymphatic system, because it's unpredictable. Every time you go there, and it looks different. For the first 6-7 years, you're doing that. After 6-7 years, you started to learn the patterns of different. I mean, I'm talking about pure clinical experience. I'm not talking about what we actually can image. And this simplified classification, liver, intestine, soft tissue, just give us a kind of guidance or something to simple clinical minds to rest on, because we need to address liver lymphatics, we know right now, intestinal lymphatics, or peripheral lymphatics. And that's kind of, we decided to separate it into 3 groups.
That's one reason I kind of like the tool that you've gotten, you've implemented here, because it could actually be used in, you don't want to do this in patients, of course, but you could be using it in larger animals that kind of represent, like you're talking about in pigs would be a good one.
Oh, absolutely.
To start looking at the,
Absolutely. We do, when we put the pigs in CHF, what we do, we bring them downstairs, like in our place downstairs, to the MRI and image, and we have this amazing data of understanding. But still, the problem is, when you inject lymph nodes in the groins, you only image insignificant part of the lymphatic system. Only it's lumbar and thoracic duct, right? What about liver? What about intestine? That's where we have to go. This is holy grail of all, at least one more time, from my clinical perspective. For me, it's holy. If I can figure out how to image intestinal lymphatics, I can treat a lot of diseases. I even think right now that celiac disease somehow related to that. I don't know. I mean, it's all intuitive, because I have few patients who have these diseases and like with lymphatic conductive disorder, all this lymphatic conductive disorder, we call it, and have a celiac disease. And parents ask me, it's like, yeah, maybe there's something there, right? Definitely liver, if we can figure out how to image liver lymphatic system, we can find more diseases that can be explained by that system. Thanks, Al.
Thank you very much.